lo escucho
Can you hear
aquí
me?
así.
You have to switch it on, and now you can hear me. Okay. Okay.
A ver si lo escucho ahí. Hay que ver.
So, good morning, each and every one of you. I'm happy to welcome Dr. Zaldivar from Argentina. Thank you for being here. He's from the Institute Zaldivar, and he shares us his experience with Presbymax and with the Amaris laser. And he's now, I heard, about 7 years in the field of ophthalmology for this refractive surgery. And you are also president of the Refractive Alliance in the United States here. So I give you the microphone, and we are interested to hear. Thank you.
Thank you, Thomas. Thank you very much. Thank you for this kind invitation. The idea today is to share our short experience with the Presbymax, but I think it's more than valid. But we have more than 10 years of experience in Presby LASIK in general, so we always learn from past and try to apply it in the present. So these are my financial disclosures. I don't have any financial disclosure with this company. So let me first introduce with something that I've been pushing lately, that is the term optimized patient. We are, as refractive surgeons, we always try to speak about the holy grail, that is achieving a happy patient. I think happy is a pretty simplistic term, and you can get a happy patient by decreasing expectations. And today what I want to share is the concept of optimize, that is when truly you really create value, that this is all about, this creating value. When you use the best technology available, trying to fulfill patients' expectations, considering their lifestyle, that's extremely important when you do refractive surgery. You need to know a lot about the patient, a lot about their functionality, and of course, always taking into account the clinical status of the patient. So it's very easy to do this today with intraocular lenses. We have tons of intraocular lenses when you are not living in US, outside US, in Latin America and Europe. We have a lot of variety with different technologies. We mainly are using torics, we are using a lot of EDOF, and we are using trifocals. And of course, if you ask me what is my favorite technology of IOLs today, I can tell you all of them. All of them. Why? Because it's not about which technology, it's about how you use it and where and when. So we are mainly doing 70% of premium IOLs today. This is just to show you 1 month, was this year in January, my own, I did around 70% of premium IOLs. In a country that has 40% of inflation, with recession and everything. But it's how can you twist and really get to that tailor-made procedure and get these premium procedures done. The key, as I always say, is creating a tailor-made procedure. It's not one suit for everyone. It's adjusting that treatment to that single patient and spending the time to do exactly what we should do. But what happens when you have a patient that has between 45 to 50 or 60 emmetrope? Are you going to put a trifocal IOL? Are you going to put an EDOF when they are 20/20 for far with 45 years old? That's extremely aggressive, and you are very likely to really get someone annoyed with you. You can do it, but it's true that you will have to decrease the expectations to the floor, and once in a while you will have a happy patient, but that's not the typical case. We need to have a large number of patients. So patients that have less than 1 diopter of mean absolute error, or patients that have a perfect OSI. You have a 55-year-old patient, 20/20, 0 of error with no scatter. What do you do? Are you going to go inside the eye and divide light with a multifocal IOL? It's not the easy patient. So these kind of patients are the one that I'm looking for, and I truly think that there is a huge niche of this in our field for this kind of smart procedures, smart corneal procedures. So we have a lot of experience with Presby LASIK. We started in 2008, and we have more than 1,000 procedures done. We used the platform of SupraCore, of Technolas in those days, with more than 1,000. And we play with all the profiles. We play with 2.3 of diameter, 2.5, 3. We combine different near ads. We put more power, less power. And the truth is that we have very good results. What was the problem? The problem was that we had We have very nice near vision. I'm correcting near vision. 83% were around 20/20 after the procedure. 92% were binoculary distance 20/25 or better. Near vision wasn't a problem, but we have around 8% of patients that really lose best corrected lines. So that was something that really started at least calling our attention, because we were very aggressive to try to give the most near vision, but we were realizing that after that the patients were good functional, but we couldn't get to the original best corrected vision. So we were creating too much aberrations in the optical system. And that's exactly coincident with what this paper and this shown by peer review, that they lose 9% around 2 lines. So it was pretty the same that what was our original experience 9 years ago. And something that really caught my attention in those days was regression. The more aggressive you are in the center, the more you get more regression. The more aggressive is that transition, the more likely you will have regression. We have several patients coming back 3 years after the procedure asking for an enhancement. We have to relift. We start with epithelial ingrowth. But I don't regret having experienced that, because now we are targeting a different kind of patient with the Presbymax from the scratch. What are we doing today? We are creating a biaspheric treatment, and we are not targeting for a very aggressive profile. I was sharing this before the presentation. My aim today is to create a very smooth profile and to get telephone reading. And this is something I haven't discussed with the company. It's my own short experience, but I have changed completely my objective. Why? Because we are targeting patients with 45, 50-year-old that with a telephone reading, if they can consistently read that telephone, they are more than happy. So expectations, I'm not saying that they will never use glasses again, like I used to say with Supracor, and I get then very annoyed patient. I changed the way I introduce this. I'm saying we will rejuvenate your vision. I want you to take you back 10 years ago and start living again this functional vision, to read your food, to do this. In order to do this, we are adding less power. So these are the options that you have today. You have 2 binocular treatments today, the micromonovision and these are both the micromonovision, and you have the other one that is the hybrid. There it is, the hybrid. So which is the difference between them? You have in both, of course, you have a little bit slightly more aggressive near power in the non-dominant, like it should be, but in the dominant, the hybrid gets both targeting 0 for far, but they have a pseudo accommodation because of spherical aberration. They have a 0.4 to 0.9 of near add in the middle, so they read binocularly. That's very nice in some cases where you have a hyperope or you have a myope. It's good because you have that range, but I wouldn't recommend this for an emetrope. If you do this in an emetrope, of course, you are taking some distance from far, and that's you're doing in emetrope everything. Okay, then we will discuss a little bit. Then we can discuss. But I really want to stay in that balance of patience and respect for our vision and get that functional. I changed my strategy. Then we can discuss a little bit. But mainly now we have the ability to select between 3 treatments, and not only this. The most interesting thing is that you can change the addition. The addition is at the beginning is set up at 1.75. That is very good. It's an aggressive profile. But what we have done, and I don't have it here, but just to share with you, we have done it. We are adjusting that addition depending on the age. I understand that if you put less addition, the treatment will be less in time, and they will need in the future. But that's something we talk with the patient. For example, we have a 47-year-old patient that is a very famous guy from the TV, that he is always talking about football and needs very good far vision to see the match and to see the faces. The patient was +1 with cycloplegia. +1. Would you do in that patient a micro monovision or a hybrid and put full power? He's likely to be a little bit annoyed with his far vision. So in those cases, we prefer correcting far vision in the dominant eye and putting with monovision in the non-dominant and adding less power in order for him to have like an optimized LASIK procedure. So instead of doing a LASIK, you are doing an optimized LASIK procedure. So the idea now is to have patients that you can adjust, as I said before. You can do it binocular with micromonovision, like you have here, more aggressive profile for near, works very good. You have the hybrid, it's a little bit less aggressive for far, but you still have binocular summation, that's very important. And then you have the monocular, like I have said, that is far vision, completely isolated for near vision. Here, I was sharing before the presentation, something very important, that is the test that we do before this. And then we can discuss a little if you do have a special test. But what do we do? I call it the flexibility test. The flexibility test is when you get the patient to a phoropter, you put in a phoropter, and you put first far vision. You get the patient to 20/30. And then what I do is I make the patient close his eyes, and I defocus to 0.75 in the non-dominant eye first. 0.75 or 1 in the non-dominant and make them open their eyes. Most of the times, patients don't realize that they are defocused. Most of the time, that's green light, perfect. Very good sign. It's flexibility for far vision. Then I do the near test, and I make them close their eyes, and I adjust it, and I put 1.75 with a near target and see what's the reaction for near. If they have good binocularity, they were going to be very, very good near reading. They are going to be fine. Some patient will tell you, I cannot read. And then you have to start digging. Some guys have an exophoria when they were young, and they have some suppression. That's very important to us to address if they have really the ability to read with a non-dominant eye. In these cases, in the cases of monocular. But all those tests are the ones that you should start tailor-made, because then you can adjust exactly what is the power that they tolerate. So you can put 1 diopter in the non-dominant at the beginning, and then jump to 1.25 to 1.5, and start seeing what is the maximum that they tolerate of the focus, and you can be more or less aggressive. My objective is to show you that the idea is tailor-made procedure, adjusted to every single patient. It's not one recipe for everyone. It's creating that specific for everyone. So let me jump directly. You have seen all this. This is very consistent. Presbymax hybrid is delivering the best results today in terms of balance between far and near. This has been demonstrated. They have very interesting near with J1, 95%, and far vision is very, very good too. But what do you do in a patient like this? 56-year-old politician is running for mayor of my city today. Very, very athletic guy. Look at his far vision. 0, 0, 20/20, 20/20. Would you be comfortable doing a binocular treatment here? So here is where I think that we need to be very careful and do the correct testing in order to be successful. What did I decide to do? I did first this flexibility treatment. We tried. I don't like the contact lens. You can use it, the contact lens trial. Many patients are not used to it. They feel strange. I really like spending in the examining room that time with the autorefract, with the phoropter, and playing with that and seeing the reaction, the face of the patient. If you spend the correct time, you will realize when they are flexible and they are very picky. If the patient, as soon as you put 0.75, they open there and say, no, I have double vision, I'm not comfortable, it's probably going to be a pain. I started doing this in Supracore, and we really were very successful with this. So what we decided doing was, this is the topography pre-op, we decided doing a molecular treatment. And the addition that I planned was 1.5. So for this guy with 56, it's a very soft profile. I under-promised a little bit the result for near. I told him you are going to need glasses. You are going to need glasses for reading a lot. I only want you to read your phone and to move and to see your computer and be functional in your politician career. And this is what happened one day. The patient was 20/40 with -1. That is what you might expect, because the laser is set up to leave you 0.87 of myopia. That's the target after the procedure. Plus the spherical aberration and the profile as sphericity created, you might have around 2 diopters of pseudo-accommodation. That's very good. And this is what happened. So the patient now, one day was 20/40s. You lose some lines from corrected, then they start improving, but best corrected remained the same. That's very important. 20/25 was for near, day 1, very happy with the near vision. Something that you need to highlight in all these profiles is that you do need light. Light is important because they are all pupil-dependent system. We are creating hyperpolate cornea in the middle, so you need the pupil to constrict, to have more power. If they want to show off with their friends in a restaurant with sushi at nighttime, it's difficult, truly. So that's something that you need to discuss at the beginning. So, but this is the profile. This is how the profile looks like. It's very nice, very nice, very big optical zone, very nice optical zone, very smooth. That's why they don't lose lines. And this is 1 week post-op, 20/30. Far vision starts getting better and better, 20/20. And look at the intermediate vision. This is what I want to share with you. This is a perfect defocus curve. If you see, look at the intermediate vision. It's amazing. This is what this guy is so happy. He tells me, I'm so happy with all this, with all the extension of the hand. And if you do the summation of both eyes, he hasn't lost a single line. He says, you know what, only if I compare, I can realize that I lost some line. Only if I compare a little bit. But if you see the simulations with eye view, it's pretty much the same, because the profile doesn't have a lot of aberrations. This is what it was before the procedure. Now he has some spherical aberrations. The sphericity has changed. And it's mainly creating smart aberrations in the cornea. This is the MTF pre-op and post-op. You might find a little bit the PSF a little bit more. That is something that is happening, is true, because we're adding some aberration, some control aberration, but still has almost the same pattern before. They can see more or less the same. And with both eyes, they are pretty, very happy. So you are not inducing aggressive aberration. So my idea today is to show you what we did before with supracore and how we are targeting today. At the beginning, I wanted to be extremely aggressive. I have the promise that I don't want them to use any more glasses. Today I'm changed completely my strategy. I'm saying, you know what? I'm able to rejuvenate your vision, to read for your everyday task, to have your phone. And that way I can be more aggressive, targeting a bigger amount of patients, because I know that I can deliver it in an easy way. You understand the change? I'm not looking for every single patient to get rid of glasses. I'm looking to correct most of the patients that are there over 45 and not putting intraocular procedures. I prefer doing this today, very easy, very fast. So very controlled profile, very soft profile, very controlled. And I like to leave it for discussion. We have done around 20. We have done it with different, it's a very small number compared with you, I guess, because we started this year. But with our experience in supracore, I was part of the clinical advisory board and everything. We done more than 1,200, and I have evolved in my thought on this. And the 20 patients that we have done are extremely happy, because we are targeting a different market in a different way. And so I'm open for discussion. Thank you very much for your attention. So let me ask you, Ivan, because we were discussing before. So if you have a patient with +1, 50-year-old, what would be your input? Because you have much more experience. So what is your counseling with the patient? What do you tell them? You tell them that what is your promise, your value proposition for the patient today?
Okay. I say that you're going to read J1 right after the surgery, but your far vision is gonna be very bad, at least for 2 months. Quantitatively, you're gonna see 20, 30, 4 days after. But qualitatively, in quality of vision for far, it's gonna take at least 2 to 3 months. Don't worry about that.
What happens if they have previously to the surgery, if they have good corrected vision and they are using their glasses? Because differently if the patient comes with like happens most of the time, they come with 0.75 or +1 and they don't have the vision corrected, so they are not using glasses. I understand that one, but if they have perfect vision for far and they have their glasses, are you happy doing the full both bilateral treatment? Yes. Okay.
There is no magic. You're gonna change your good vision for far for a more or less for far, more or less for intermediate vision, and good for near. And good for all distance in 4 months.
I agree, and it's all about talking with the patient. My feeling.
6 months.
Yeah. No, for the phone, because if he's reading 20, that's it's if you have this for the phone, because he has 20/20 vision day one. He will start perhaps losing some in the future, but as soon as he gets to 20/25, 20/30 for near 40 centimeters, but he's 20/20 at 50, I'm happy. You see? So my experience in the past and was that if I was very aggressive looking for near vision at the beginning, it happened like that. They take 3 to 6 months to stabilize for far. So I prefer today changing that strategy to do it less aggressive at the beginning and decreasing a little bit the expectation for near and having that far vision very consistent, very solid from not day one, but month one, because every day they keep improving, but having very, very functional near vision intermediate.
So you do believe that this is not going to change? You believe that this situation is not going to change in the future? You're going to have the same situation?
No, but he's 56. He doesn't have more accommodation. He has less.
What are you going to do
after in the future? When not, I'm not. That's the point. I'm not saying that he's not going to use glasses anymore. That's not my objective. So I'm just saying he's going to rejuvenate and eliminate the daily functional vision. I want him to read with his phone. This is just this case of monocular treatment. Of course, if you have a patient done binocular, and we have patients with monovision and the other and the hybrid, that this works very nice. I like a lot the hybrid. They are extremely happy. I'm not saying that they are not worthy. They are very worthy. My only piece of advice is, why don't we think a little bit in decreasing the near out a little bit, not aiming to not lose any more glasses, and lowering a little bit the expectation for near to have a more consistent far vision from before. It's just a proposal. I think each one has their own strategy and everything, and it depends on everything. But we used to do the same with supracore at the beginning. That is completely different. I show the profile has nothing to do with this, and we used to speak of a patient in 3, 4, 6 months because they were very aggressive at the beginning, and at the end it was like a short blanket. So if you want to be very good at near, we have to take some from far. If you want to be very good at far, you have to take a lot from near. Now it's like we have refined, we have polished the message, and we are targeting in a different way. So it's just a try. We need, of course, more number and everything. You have much more experience, but I think it might be more universal. Today still is a niche, because if you think about it, every patient in the 40s should receive a presbyopic procedure. In 45, 46, there's no explanation why you do a regular LASIK. But the idea is, don't give 3 diopters of near out to someone that doesn't need with 46, despite in the future he might need. But I prefer being comfortable and then perhaps using something, but he will always have more depth of focus than the original treatment. Always. So that's it.
So, Jovan, I have two questions. The first one, you have any consideration about the pupil size when you indicate this Presbymax? And the other question, if you needed to enhancement in the future, do you do the same Presbymax, or you just treat the aspheric like +1 or +1.5 if you need to enhance them in the future? You know what
I haven't enhanced a single Presbymax since I started because of my new paradigm with this, but I've done it in the past. And I try to avoid doing a lot of enhancements in this kind of patient because of possibility of capillary ingrowth. It's just what you tell the patient. Just what you tell the patient. I prefer, if I have to do an enhancement 5 years after in a 50-year-old, to do a monocular IOL, and leave it a little bit myop, and that's it. Not relieved after 6-7 years these hyperopic profiles. I prefer. I have done it, of course. I've done it, and I've done it several times. But today I would do a monocular IOL inside, targeting micromonovision, and that's it. At least. And the pupil size, it depends. I don't have the experience with this profile, but I would be concerned if the patient doesn't have less than 3 millimeters of photopic. I would love to have it a little bit less. In the recommendations, I don't know, some is there, it's around 3.5. Yeah. Ruben, are you using Presbymax?
No, I really don't believe in any hyperopic procedure in the cornea. I prefer to go with the intraocular treatment. And I don't talk to people that see 20/20. I tell them that if they want that, if they want to have a procedure, they're going to lose distant vision. They're not gonna, and usually they're very picky. They are people that are happy with their distant vision and they don't accept to lose anything.
Why? Let me ask you, because it's good to hear a different voice. Why would you be against hyperopic profile in the cornea? Because what we experienced in the past, or why?
Because the effect of the treatment disappears with time.
Why?
Why? Because it does.
Because in the past we have played with very aggressive transition zones, very aggressive zones. If you have a high, very big optical zone, we are doing optical zones of 7 today. 6.8, 7, it's huge. You take the transition to the periphery, and the transition is so smooth that Charla has shown this, you won't get regression. What you will get is the manifestation of the latent hyperopia. So be careful, because there are two things. And you know how you can demonstrate this? With the case, with the K reading.
I think has been an excellent presentation, and you really hit the point. We as a company, we can only provide you tools that allow you to do whatever you consider is proper for that particular patient. But you have made all the effort to even deviate from our recommendation and reduce the addition and this for the sake of your patients. So you cannot expect that we give you a magic wand and then the laser will do the job for you. The laser will do the job in the cornea that you ask the laser to do.
Right.
But your explanation, I think they were very convincing that at the end of the day you need to understand what the patient needs. You need to promise what you can promise and eventually under-promise, and not expect to cover all the distance. I think this part was great. Concerning the comment of the regression, or whichever name we're going to call it, I have just submitted with another group a 6 years follow-up on Presbymax, and exactly looking at the K readings and looking at the Q values and looking at the corneal spherical aberration, there was no change whatsoever in 6 years of time. And yet, in 6 years of time, there was about 3/4 of a diopter hyperopization, both in the dominant and in the non-dominant eye. And this was exactly as you pointed, it was more or less 1/8 of a diopter per year. But these was lenticular changes. The cornea was there,
the spherical elevation was there, and the ones that have been treated now after 6 years, they have been treated with a simple wide optical zone hyperopic profile, non-Presbymax, because the spherical elevation was still there, was only bring that latent hyperopia back to the target. But I think you really nailed the point, and thank you very much for that.
That's mainly why I relaunched my presbyopia correcting with laser, because I have completely abandoned it. And now when we start seeing the new profile, the big profile, and we finally understood that we have to modify our brain of what we used to look for in the past and target a different patient. And we have seen this because we are using a lot of IOL comfort, no financial index too. You know the comfort of oculentis? Have you seen it's 1.5 diopters in the bottom? And those patients are extremely happy. They are 96% of satisfaction. And we were always saying, no, you have to read, we need very aggressive near vision. And they are very happy with their functional vision, just telling them that they will need some. So we have changed completely the way we focus on, and perhaps that's something, because if you think about it, Presbymax has been here for many, many years. They have been improving. They improved from symmetric profile to micromonovation, then to hybrid, then they are constantly delivering and improving the product. But then it's our job, as he's saying, to look how we can grow our market and how we can consolidate the product. I think that it might be interesting just to check in some patients, in a group of 10, 15 patient satisfaction. If we modify a little bit, we just tell them that they will need glasses, and we hit in a much softer profile for intermediate, and tell them that in the future they will need glasses. I think it's worth it to try. So thank you Sam, for the invitation, and hopefully next year I have a big data and to show. That's my main objective, is to consolidate really the data and show you very nice data next year. So thank you.
Thank you.